Okay, we're going to go to Representative Morrison, House File 521. So Representative Morrison's motion that House File 521 be laid over for possible inclusion in the finance bill. And I do, oh, I'm sorry, I've got this a little backwards because this is coming to us from as a division report. So Representative Freiberg.
Thank you, Madam Chair. I'd like to move that the committee adopt the report of the Preventive Health Policy Division for HF521.
All right, so this did receive a hearing in the Preventive Health Division. So any discussion to the adoption of the report? Seeing none, if you'll unmute yourselves, members, all in favor of the adoption of the report, please say aye.
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 Any opposed? The motion prevails and the report is adopted. And now it would be Representative Morrison's motion to have House Bill 521 be laid over for possible inclusion in the finance bill. And Representative Morrison, I believe you also have an amendment. Is that correct?
Madam Chair, that is correct. It is a technical amendment that removes a duplicative word.
Okay. All right. So Representative Morrison is moving the A1 amendment to House File 521. All in favor of that motion, please say aye.
Aye. Aye.
Any opposed? The motion prevails and the amendment is adopted. And then members, as I said, this did have a complete hearing in the Preventive Health Division, but we do now have a fiscal note, which members received. It's unfortunate that we don't, we're getting these, of course, as we get toward the deadlines and so on, we get these without a lot of time to read them, but it is before the committee. And I don't know, Representative Morrison, have you had an opportunity to read the fiscal note, and did you want to discuss it at all, or do you want to just kind of briefly, maybe just briefly present the bill and talk about the fiscal note if you care to do that?
Thank you, Madam Chair. So very briefly, many of you will recall that House File 521 would extend Medicaid coverage to mothers for 12 months postpartum from the current federal mandate of 60 days, which is what we have in Minnesota. We have a mental health crisis, we have a substance use disorder crisis, and we have unacceptable racial disparities in maternal and infant outcomes in our state. We have to find a way to provide care for our new mothers during that very vulnerable first year. The fiscal note did come out today, and I have glanced at it. I have not been able to review it exhaustively, unfortunately. But it looks like, if I recall, this would apply to about 4,000 people a year. I don't know if Mr. Berg is on. He may be able to describe it in more detail.
I was just going to suggest that, Representative Morrison, you don't need to, if you've just had a bare chance to look at it like I have, let's ask Mr. Berg if he can walk us through the fiscal note briefly. And Mr. Berg.
Madam Chair, Representative Morrison, very high level, the number of cases it applies to is not something I have yet got in my mind. It is, I believe that Representative Morrison is right. If I'm looking at it, it is just under 4,000 monthly cases, I believe is the number. As I say, I've not read it in great detail myself either. The total cost as the bill stands now is about $9 million in the first biennium and about $29 million in ongoing in the tails. There may be ways to scale this benefit somewhat as well.
Yeah, okay, thank you, Mr. Berg. And does anybody, unless anybody has questions about the fiscal note, and I'm going to assume that most members haven't really had an opportunity to read it either, because it did just come, and there's a lot of narrative in it, which is, really interesting. Honestly, I got partway through it, and And so this is certainly something that we'll have an opportunity to discuss again when members have had a chance, if there are questions about the fiscal note. So with that, anything else, Representative Morrison, that you wanted to see? Oh, I'm sorry, I do see we have a question from Representative Pryor, please.
Thank you, Madam Chair. Yeah, I did have a question about the fiscal note. It's around the IT, and I guess my question to Mr. Berg is it typical for a change like this to really take an 11-month window and 20,000 hours of work? It seemed, you know, just based on my background in helping lead technology projects, those surprised me. I'll just leave it at that and wonder if that might be something to explore. There are some assumptions that or ways to implement the bill that could address that.
Mr.
Madam
Berg?
Chair, the general topic of IT costs and DHS's and Minute's ability to implement them is an ongoing issue and has been for many years. It could be a whole topic for discussion of IT systems at DHS. They have many systems which are often old legacy systems that are require a lot of work to change them. Broadly speaking, almost any change we make in benefit structure like this has IT costs related to it. It is not only common, it is to be expected at DHS. And delays or a longer time period of getting changes like this made are also frequent, I guess I would say, or common. It's they're, in addition to just, there are many changes that need to be made on an ongoing basis, and also the systems are difficult to work on, and so yes, this is an ongoing issue.
All right, and I understand that Sarah Orange is on the call and could maybe speak to this. Ms. Orange, did you have anything you wanted to add? Welcome.
Hi, Madam Chair, yes. This is Sarah Orange from DHS, thank you. To discuss particularly the extensive nature of the IT work, I'd actually defer to my colleague, Gina Savage, who's on the line as well.
Okay, Ms. Savage, welcome.
Madam, hi, this is Gina Savage. I am a healthcare policy analyst at the Department of Human Services. Madam Chair, Representative Pryor, as Mr. Berg mentioned, anytime we touch our IT systems, there is going to be an IT cost. With this specific proposal, it would be extending a postpartum from 60 days into a year later. So we would have to go in and adjust that. When a woman is eligible as a pregnant woman, she is exempt from renewals. So anytime there's a renewal, so this proposal would affect renewals, which increases some of our IT lift. And then pregnant women are also exempt from income increases. So once a woman is determined eligible for MA as a pregnant woman, even if her income increases over the 278% threshold, she maintains her MA eligibility. So we also have to make sure that that is implemented across the entire 12 months. So not only are we touching the postpartum period, we're also touching our renewals functionality, our changes in circum functionality, as well as some of our notices, and then of course, any kind of interfaces and updates that we have to do on the coverage side as well. Thank you.
All right, thank you, Ms. Savage. Okay.
If I may, Madam Chair.
Yes, please, Representative Pryor.
Thank you. Yeah, and I of course expect there to be IT costs, and I lived in a legacy world working in project management of Blue Cross. So I know legacy systems, so I feel your pain. Just the kind of suggestion that struck me though is that, and this is an opportunity, not a criticism by any means, is that the language of the coverage is based on number of days, but coverage in the IT systems is based on months. And so doing days is much harder than months. So I would wonder to the author, could this be recast in terms of X number of months postpartum? And it's thinking about those types of things that can help make very little substantive change, but a lot easier from a technical perspective. Thank you.
Yeah, thank you, Representative Pryor. As I read the note, I think that they made the assumption they kind of did that conversion, but I don't know whether, I certainly hope that they'll reach out to the author if there are tweaks to the language that would help reduce the cost without reducing the impact on people. I certainly hope that they would step forward and help us with that piece. And I do have a question as well. And I'm not sure, I don't think this would be for Ms. Savage. This is more about the eligibility issues in the bill. And the fiscal note says, it talks about that actually only 20% of MA pregnant women are redetermined ineligible after the 60 days, but that a lot of the other women are moved to a different category of eligibility that is less expensive. So this was kind of news to me. So being a pregnant woman in that category is apparently more expensive than being let's see, what is it? It just goes from a pregnant woman to be an adult, I think. Maybe I've got that wrong, or parent, probably parent. And I'm just really interested in, that just, well, obviously people when they're pregnant, they need additional health care. But, in this postpartum category, I just wonder if the amount of care that they would need makes them so much more like pregnant women in terms of their expenses than it does as women, adults with children, I guess, if that's what it was in here. Is there anybody that can really address that kind of? Is this because we're talking about managed care? Is that what this is about when you put them into the managed care system? What the capitation is for them based on this category? Is that what we're talking about here? Ms. Orange, can you answer that for me?
Madam Chair, I can certainly attempt to answer. So as you noted, the fiscal note assumes that a proportion of these women, actually a large proportion of these women, would have remained covered even without this bill. They would have been redetermined as eligible in one of our programs and been shifted to most likely the parent eligibility basis. For the fiscal note, essentially what we did is we pulled claims data for women historically in our system that have been in that situation where they gave birth on our program and then were redetermined into a different eligibility category, and pulled their actual claims to determine how much claims experience we actually have, how much we see them actually utilizing services. And so that's where we came up with, I believe it's an average of maybe $700 or $750 approximately per month that we're using as the basis of the fiscal note. And so that is somewhat higher than the average cap payment that we do see in terms of managed care for the parent eligibility category. With that said, when this is implemented, obviously, to the extent that these folks do end up in a managed care plan with a managed care plan, and the rate setting process for managed care would look at actual data to determine kind of what the correct risk pool and what the correct capitation rate would be. And so for the purposes of the fiscal note, we merely looked at our old our claims data to assess approximately what we think kind of these women's utilization would look like. And so it's an approximation on our part.
Okay, that's very helpful. And then, since I'm asking these questions because we do have a few minutes, and I think we do have this really complicated fiscal note, which for something that seems so simple and intuitive, honestly, and the fiscal note's so complex. But do we have any way? So this is, I think then the fiscal note is kind of assuming that many of these women will be in managed care, right? That's kind of the assumption here. So what is there, and maybe this would be for the author too, what would their care look like? I mean, how would we assure under the bill? I mean, the bill is so important to make sure that women get the kind of follow-up care that they need to reduce their risk of having a terrible event, to make sure that all these issues are dealt with during that first postpartum year. And even if we pay for this and put them in managed care, do we have any assurance that they'll actually get the care that they need to address these issues? Are we because I don't know, either because they're in a particular category. I don't know if that means there's a standard for what they get in terms of how many visits, or, do you understand where I'm going, Representative Morrison? There's a little disconnect here, like, yes, we should pay for them to have care, but will they get the care?
Well, Madam Chair, I can certainly speak from clinical experience about that. And I think there's a growing realization in obstetrics and gynecology and internal medicine that women need probably more care. Many women need more care than they are getting in that first year postpartum. So we know that a third of maternal mortalities occur between a week and a year postpartum. And so, for example, if someone had a hypertensive complication during their pregnancy that continued past the 60 days postpartum, they would have nowhere to go other than an emergency room in a crisis after that period of time if their coverage expired. Whereas they could have a detailed care plan with their provider that would follow them throughout that year. If they had a history of a blood clot, if they had cardiac disease. Some people have cardiac disease is now the #1 cause of maternal mortality in the United States. So a detailed care plan could then be devised and followed, whereas now there's just this gigantic hole in their ability to receive care. And so the emergency room is kind of the only recourse. And then of course our struggles with substance use disorder and with mental health complications also require ongoing intensive care, and those people don't have access to that right now.
All right, thank you. That's a really helpful answer, Representative Morrison. It's wonderful to have a member who's also a physician who probably delivers a lot of this care. So thank you. Representative Pryor.
Thank you, Madam Chair. And well, I was fortunate enough to sit on also the Preventive Health Committee, and we did hear how important this bill was, and glad that we're hearing it again and discussing the fiscal impact of it. And if I can just keep kind of following up on the line or at least I probably am misunderstanding, but I just want to make sure that this is that we can get this put together in the way that works for this group of women that we're trying to serve here. So on the one hand, it sounded like the description of it is that they'll be moved maybe from the fee for service into the managed care insurance, and maybe I was misunderstanding that, but then my real question is, however it works, as we're listening to Dr. Morrison, it seems like the people need to be followed by the same physician. And is that going to be possible the way that this is being written right now, and how their insurance coverage might be changing? Because if you're writing a care plan, it should be that the same person that saw you through those first months when you were carried under one plan can continue to carry. And I think that is the intent of this, is a continuity of care. And now as we get into fiscal notes and assumptions made by DHS, is this going to happen the way that at least we were talking about in preventive health, I guess?
Yeah, so thank you, Representative Pryor. I'm not sure if, we didn't really get what you just said about starting out fee for service and then moving to managed care, I'm not sure if that's the case. And I don't know, Ms. Orange, can you address that? I know I asked you whether they would be in managed care, but we didn't really talk about when a woman comes onto our programs because she's pregnant, how does that work? And is this going to be, can this be something where she can get continuity of care? She's not bumped from one program to another.
Yes, Madam Chair, Sarah Orange again. It's my understanding, and I want to preface this that I am not the managed care expert, but it's my understanding that most of these women are typically on managed care for the duration of their pregnancy period. And so I don't believe it's the situation where we'd see folks necessarily bumping back and forth between fee for service and managed care, is my understanding.
Okay, does that help, Representative Pryor? Yeah, okay. Well, very good. All right, well, thank you. Thank you very much. And I'm glad we were able to get the fiscal note, even if we didn't have much time to review it. And I'm sure members will be interested in it now because it really does. These oftentimes fiscal notes are really the way to learn a lot about the way things work in our programs. And if you read them, their narratives especially, you do learn a lot. So thank you so much, Representative Morrison, for bringing this bill. And so this House file, let's see, what's the number? House File 521 is laid over for possible inclusion in the finance bill.